Thank you
So,
very much.
Luis,
Yes,
could you steer the presentation by Professor Oya? Could you chair?
yes, of course.
Thank you
My,
very
Thank you very much.
my great honor.
much.
Yeah, it's a great honor to me to be in this webinar of the Japanese Society.
Okay.
During the last years, you see the continued improvement of the Japanese neurosurgery. And Professor Oya is one of the examples. Now, the generation that are the new chairmen in Japan are making a big difference in the world. Professor Oya is not only an expert in microsurgery, but also an expert in gamma knife, in radio surgery. And no more than him to know the real indication for the treatment. I'm very excited to see can see the presentation of Professor Oya. I have seen him during many years meetings around the world. Thank you very much. I think we enjoyed this 20 minutes. Thank you very much, sir.
Thank you very much. Thank you, Professor Borba. It's my great pleasure to be part of this webinar today, collaborating with world-renowned skull-based surgeon like you. You know that I'm going to talk about surgery for meningioma and the schwannoma. As we all know, the meningiomas and schwannomas are very common tumors, but risk of surgical removal varies greatly from tumor to tumor. Some meningiomas or schwannomas can be removed by residents who became doctors just became yesterday, whereas some tumors are untreatable even for doctors who have fully trained as surgeons for decades. So we have a traditional Japanese concept called shuhari. This is well known in the field of tea ceremony and other martial arts in Japan. It describes three-stage process of learning and mastering things. This concept can be thought of as consisting of three stages: follow, break, and develop. So in the first stage, learners strictly follow and preserve the teachings and techniques imparted by the masters. The focus is on learning the fundamentals thoroughly without deviation. Once the basics are mastered in the second stage, learners should break away from traditions and explore a better way based on their own experiences and interpretations. And finally, you should separate from traditional constraints and develop your own original style. Of course, in the field of medicine, the stage should be safe, beneficial for patients, and universally applicable. So I think uh, here, I think the concept of shuhari fits well with the science and art in skull-based surgery. Let me briefly share this idea before presenting two illustrative cases. Let me talk about an example of follow, break, develop by focusing on so-called 4D dissection technique in meningioma resection. In resecting convexity meningiomas, we usually cut the dura first to devascularize, and then we dissect the tumor from the surrounding tissue. We should follow this well-known principle in the first stage. However, in the second stage, which is break, we need to learn how to convert skull-based tumors into convexity ones. If you adequately remove the bone around the tumor attachment, most failures can be managed during the extradural phase without the need for preoperative embolization. This approach enables you to secure the ICA and optic nerve before you start removing the tumor and minimizes the bleeding from the tumor. So this is the M1 and M2. and gross total resection was achieved, and the patient had no neurological deficit. In the final stage, which is develop, you can separate from this old school tradition. This is a hypervascular meningioma with significant peritumoral edema and numerous pyrophytes. If you incise the dura in the usual manner, you're going to have a massive bleeding. And high intracranial pressure, often associated with these tumors, may cause brain bulging, leading to contusion-like changes in the surrounding brain tissue. However, if you are incise the dura mater into small sections like this, and minimizing exposure of the normal brain, you can effectively control the bleeding even for these hypervascular meningiomas. You may sometimes encounter massive bleeding from pyrophytes like this, but since the bleeding is only coming from this location in the surgical field, so it's not difficult to identify the bleeding point and stop it. And gradually the tumors are coming out because of the increased intracranial pressure. Now it's coming out, and you can preserve the drainer and remove the whole tumor. So the whole tumor was removed with no ischemic changes around the tumor cavity. In the latter half of my talk, I will present one representative case, each of a meningioma and the best schwannoma. Let me start with our meningioma. This 56-year-old gentleman was found to have an irregularly shaped left sphenoid wing meningioma during a detailed examination of his convergence. This tumor encased the MCA and had many features from the ECA and MCA. Well, this was a hypervascular tumor. However, as I demonstrated earlier, I coagulated the features from the ECA extradurally. Then I opened the dura, but the tumor was extremely firm and strongly adhered to the brain. Using cursor, I carefully shaved off as much of the tumor as possible. Finally, I left only the portion tightly adhered to the M1-M2 junction. I left this portion. And as you see here, there is a small residue here, but otherwise it looks good. The patient was fine, having very mild aphasia, which was resolved in a few weeks. The pathology was WHO grade 2, so he had adjuvant radiation therapy, but the tumor came back in 2 years. He had multiple recurring tumors. We therefore decided to do the second surgery, but the question here is what we should do with the tumor at the M1-M2 junction. So on angiography, the anterograde flow of the MCA was completely intact. So we decided to do bypass to cover the whole MCA territory, aiming for Simpson grade 1 resection. Using the previous surgical incision, I made a skin incision in the mu shape. The STA frontal branch was harvested from the underside of the skin flap. In addition, the occipital artery was taken from the back of the head on the left side. The tissue surrounding the occipital artery was extremely firm. So I had to use scissors to sharply dissect it. And in recurrent WHO grade 2 meningiomas, these isolated satellite lesions often occur, presenting with small and discontinuous island-like distributions. So I think 5-ALA is effective for complete tumor resection by highlighting these scattered lesions. Well, this is one such lesion, which may be difficult to detect on MRI. So careful inspection using 5-ALA is very useful to avoid missing them. This is the M2 superior trunk and the inferior trunk here. Tumor encasing the M1, M2 junction. This is a small branch to the, I think that's the pre-central artery. And then we proceeded with the expanding the craniotomy. This was necessary to cover the whole MCA territory by bypass and to achieve Simpson grade 1 resection, considering high recurrence risk of the WHO grade 2 meningiomas. Now I'm starting OA-MCA inferior trunk bypass. I anastomosed the occipital artery to MCA, which is from the inferior trunk. And intraoperative ICG-VA showed good patency of the bypass. Then I exchanged the CREP from temporary to a permanent one. And I harvest the frontal branch. And actually, this was rather short for the anastomosis. So this is the technique to harvest the STA as long as possible. By prying STA and applying the temporary CREP near the skin incision, we can extend its length. And likewise, I anastomose the STA frontal branch to the M3 portion of the MCA superior trunk. Then after trapping the MCA, we waited for 20 to 30 minutes before sectioning the MCA. Using this time, I resected the frontal cranial base dura with small tumors. And I also drilled a portion of the frontal skull base where the tumor appeared to invade. As there was no decrease in the MAP amplitude, I sectioned the M2 superior trunk and inferior trunk. And I also translocated the pre-central artery to the MCA inferior trunk because we did our best because this is the left side. Then we put, this is the M1 distal portion. We put the CREP to the distal M1 and then resect the tumor, including the M1, M2 bifurcation. And there was small residual on the frontal base dura, so I remove it. So fortunately, he had only very mild aphasia, and otherwise he recovered very well. The whole MCA territory was covered by the bypass on 3D CT angiography. The second case is left vestibular schwannoma with high jugular bulb. The patient was a 25-year-old woman with a hearing disturbance over the last 1 year. Her hearing examination revealed a pure tone average of 51.3 decibel and a speech discrimination score of 20% at 60 decibel. Axial MRI T1 weighted image enhanced with gadolinium enhancement demonstrated a 2.5 centimeter vestibular schwannoma on the left side In addition, the upper portion of the jugular bulb was located at the level of intracanaliculaar tumor. CT angiograms confirmed existence of the high jugular bulb on the left side. The patient was placed in a park bench position and a C-shaped skin incision was made. After craniotomy, I drained the CSF by opening the cerebromedullary cistern. While the effectiveness of opening the horizontal fissure has been reported for cases of pontine cavernous malformations, it's also useful to create an ample working field for vestibular schwannoma. Using this V-shaped area, the risk of injury to the cerebellar hemisphere due to retraction or compression by instruments can be minimized. Using the space created by internal decompression, I dissected the superior portion of the tumor and the inferior portion of the tumor. This is the inferior portion of the tumor. And the dilated vein functioning as a drainer was safely coagulated even around the cerebellar pedicle. Opening our horizontal fissure allowed for good visualization of these structures around the brainstem. I pressed the retractor softly to protect the cerebellum and to avoid compressing it. I cauterized and cut the internal auditory artery. Even with arterial bleeding occurred, I could easily control it, making the most of this wire space. I used our microhemocrypt to achieve complete hemostasis and prevent post-operative bleeding, which may cause major complications. Again, this V-shaped working field allowed for a clear and direct visualization of the facial nerve and the brainstem, which I believe contributes to the preservation of facial nerve function and the avoidance of brainstem injury. After achieving effective internal decompression, I next opened the posterior wall of the internal auditory canal. Since this patient had a high jugular bulb, careful skull-base drilling was required. To safely expose the jugular bulb, I first left the thin layer of the bone covering the jugular bulb. Copious irrigation is critical because this enables me to recognize a slight change of the color, which indicates the location of the jugular bulb. Here I switched from the large 4 mm diameter bar to a smaller one with 2 mm drill head when guttering around the top of the jugular bulb. The round top of the jugular bulb was gradually exposed by gentle drilling of the posterior wall of the canal. Now I'm compressing and dislocate the top of the jugular bulb. When a sufficient mobilization of the jugular bulb was achieved, I then used a large piece of bone wax so that I could continue further drilling towards the fundus of the internal auditory meatus. Now I could effectively displace the jugular bulb so that I could drill the fundus of the meatus. This is very familiar view for opening the internal auditory canal. So next I cut the dura and expose the intracanalicular portion of the tumor. Because the jugular valve was completely displaced, I could obtain a sufficient space to remove the intracanalicular portion of the tumor. Meticulous dissection under the well-controlled hemostasis is the key, I think, to the safe and complete resection of tumor. Well, here you can see how I use the micro scissors and the micro forceps for dissection to keep the interface between the tumor and the nerve bloodless. We often use cotton patties as shown here. Any small amounts of bleeding which can reduce visibility were washed out using the irrigation suction tube. This layer is the residual fiber of the vestibular nerve, which will protect the facial nerve. I tried my best to preserve this perineurium layer during dissection. The open air cell was sealed with a master piece soaked with fibrin glue. And this is the final view, the lower cranial nerves. And this is the facial nerve coursing rostrally. And this is the trigeminal and abducens nerve. And all the tumor was gone. And importantly, there was no facial palsy or no contusion on the cerebellum though I used the brain retractor. Well, the existence of high jugular valve reportedly increased the incidence of air embolism during sitting position surgery. In addition, massive bleeding in such patients has been reported as well. As for surgical technique, the importance of careful drilling and the use of endoscope have been stressed. I introduced our technique of opening the horizontal fissure today, and the meticulous drilling technique and a gentle displacement of the jugular valve using cottonide patties and small pieces of bone wax. Controlling any bleeding while exposing the jugular valve should also be emphasized. So in conclusion, these are key considerations in learning skull-based tumor resection, include following and mastering fundamentals, and applying the advanced strategies based on experiences, especially for complicated cases, and tailoring surgical approach to each case for specific goals. Thank you for listening.
Microsurgery.
Yeah.
Microsurgery. See, this is where it came from. These are training you do, no dedication year and year to have this kind of dissection and results. When I see this lecture of Professor Oya, I really enjoyed and very happy to see the microsurgery in Japan is
Delivering.
alive and stronger than. Thank you for brilliant presentation.
Thank you very
And
much.
let me ask you a thing that's very simple.
Yeah.
Which drill you are using? Which company is?
That's
NSK?
Medtronic.
Medtronic.
Yeah.
Okay.
That's called
But I'm seeing the beat that you are using is the one that is covered, is the white one that is covered until the point. It's a very important technical issue. If people, when they're using the drill, they are using the wrong bit the majority of the time. The bit is out when you are in deep space among many structures or between nerves and vessels, and the only part that you need to rotate is the tip. In the perfect beat, is very important. I'm seeing some videos from people around the world they are using different bits completely wrong. It makes more difficult and more unprecise your dissection. See? And microsurgical technique, it's wonderful, wonderful.
Thank you very
Thank you
much.
very much, sir. Thank you.
Okay.
I don't know, say some questions to Professor Oya.
Luis,
Yes,
may I have one question?
yes, of course.
Actually, I was a kendo player for long years. So Shohari, 3 steps for running, is very familiar for me. So I would like to ask your opinion about the duration of each step. First step, how many years do we need? Or second steps, how many years, and so on.
It's for me.
No, no,
Oya, please.
oh yeah.
Okay. Okay. So I think it depends on the field. It's probably different from the field to field. So, well, I can say something for skull-based surgery. I mean, microscopic skull-based surgery. Well, first we have to learn how to handle the vessels like veins and arteries first, and it will take like 5 or 6 years after passing the national boarding exam in Japan, maybe.
Mm-hmm.
Then then the second stage break. We have to always think about what's not good for now, and what can we do to improve our current standard. So I think it's like it will take like another 5 or 10 years.
Mm-hmm.
Then maybe we can separate from those traditions, and we can change or add a little bit something new to our existing knowledge or techniques. So like it's more like a 20 years journey.
I see, I see. Always thinking. It's
Right.
very important, I think. I agree with you.
Thank you very much.
Thank you very much.
Okay, so there seems to be